Hello, hello, hello. Thank you so much for coming today. My name is Dr. Alyssa Marshall, and today we are going to be doing some discussion about endodontic diagnosis. Now, if you could just verify with me that you can actually see and hear me, then I will get started with the actual juicy content. So if you would let me know just to make sure that the live stream is actually working, that would be fantastic. You are probably either on the site or on Facebook or YouTube watching. Thank you, Pallavi, for letting me know. Okay, so I was going to talk about both the pulpal or the endodontic and the periodontal diagnoses today, but as I was preparing the content, I realized that we are going to go way over time if I try to cover both. So today we are going to stay with endodontic diagnosis, and in a couple of weeks we're going to do the the periodontal diagnosis. That was going to be next week, except that I have learned that Michigan has sent out interview invitations stating that the OSCE, the objective structured clinical examination, is going to be a part of the test. So I have last minute decided to change the schedule and have a workshop about that next week. And then the week following, we're going to do the periodontal diagnosis. So normally we haven't done like live workshops weeks in a row so often, but just the time is the time. So that's what we're going to be doing. So 3 weeks in a row, starting this week, there's going to be clinical workshops that I think everybody should try and come to. So that is that. And so we are only going to be talking about the endodontic diagnosis today. And now let me switch over to, was this what I wanted? This is what I wanted. The PowerPoint. And we can get going. But just in case you do not know me, you have no idea who I am, and this is your first time with me, I'll just take a brief minute introducing myself. Most of you who are here, I'm fairly certain you do already know me, and maybe you've been to a workshop or two that I've had before. But this is me. My name is Dr. Alyssa Marshall. Myself, together with Kevin, we are the two people behind the scenes at International Dentist Central running the show. Starting 2013, we have been helping international dentists get into advanced standing programs all over the country. I, like myself, was a internationally trained dentist. I was trained in South Korea, and I, like many of you, it took me 2 seasons to get in. Now this is common, but what was a little bit uncommon with my case was how the stark contrast. So like the first year, I did manage to get 2 interview calls, one with and one without a bench test. I didn't work out with either of them, but the next cycle, I ended up getting 6 or 7 acceptances, and that's after I decided to stop going to interviews. I ended up deciding to go to UCLA, and after I've made that decision, I stopped attending any more interviews and declining those. So that's not exactly where I saw myself the first year. I was just like, oh, just please just one program, say yes to me. That's all I want. Otherwise, I was ready to go back to my home country. But then the second year, things worked out so well for me that I started to help out friends, and then my friends told their friends after they got accepted. And so I started to get these random emails from people that I didn't even know, asking if I could help them. And 1 became 2, became 4, became 8. And I joined forces with my partner, Kevin, who has admissions experience. And so we made a really good team, and that's how International Dentist Central became official and it was born. So that's a little bit about me. Clinical interview course. This course is going to launch next week. It was way overdue. And I say this because every single year we've been getting people ask how to prepare for the clinical part of the interviewing side. So we have courses already, right? We have bench test mastery to help you prepare for the bench test, and then we have interview mastery to help you prepare for the personalized questions for the interview. However, what was lacking was the clinical interview, like the case-based studies or radiographic interpretations or things like this. We didn't really have a course for this. So like I had been doing private consulting sessions with clients for this entire time for several years to cover the clinical interview side of things. And then COVID happens this year, and we just got so many inquiries, and I don't know why it never occurred to me, like, oh, I should actually make a course about this. It hadn't occurred to me before then. So we finally got the hint, like, okay, we need to have a way to help a lot more people than the people that just, come to me for private consulting. So that's how we decided to put together the clinical interview course. And the link to the clinical interview course is on our site. If you're watching this workshop on our website, if you refresh the page, you'll actually see a button to go over to our site to actually see the course page. There's not a lot of information on there right now, though, but it's going to be ready to join if you are interested next week. And yeah, so what I'm doing right now of the endodontic diagnosis is a live recording of a module that's going to go inside the clinical interview course. So there's not going to be a replay of this anytime soon because of this, but this workshop that I'm doing right now is going to be edited and included inside the course, as is the objective structured clinical examination module and the periodontal module that is also coming up. Those are all also going to be live recordings of modules of the course that'll be edited and included inside of the course. So just wanted to give you a little bit of information on that. And now we are ready for the endodontic diagnosis. And before I get to this, I should just give you a background now that I am not very good at multitasking, as in looking at chat while I talk. So what I'm going to do is I'm going to go section by section, and at the end of each section I will take a look at the chat and answer relevant questions, and then we'll get back to the content. So I'm going to go section by section. So if you have any questions that pop up in your mind while you are with me at this, just type it in the chat. And whether it's our website chat, which is at internationaldentistcentral.com/workshop, or whether you're at like Facebook or YouTube chat, I will be able to see it. So just type in whatever platform you're on watching me from, type in your question, and I will try to get to as many as I can. Okay, so endodontic diagnosis, and the way that this module itself is structured is we're going to talk about it has 3 chunks to it. Okay, the diagnoses, like how to diagnose, and then the pulpal, and then the periapical diagnosis. So that's like just what's coming up in a big picture. So endodontic diagnosis. Endodontic diagnosis includes both the pulpal and the apical tissues. And sometimes this is like easy to forget, which is why I made a separate slide about this. It's not just the pulp, it is the apical tissues. Apical tissues may or may not be involved, but we have to look at both to be able to come together and create a diagnosis. We need a lot of examinations to be able to provide a accurate diagnosis for this though. So medical history, chief complaint, if they have it at all. Sometimes they might not have a chief complaint if the pulp is just dead but without symptoms. There are lots of situations or scenarios. So chief complaint, if any, we need to look at that. We need to do a clinical exam, we need to do clinical testing, and we need to look at radiographs. So medical history, standard, right? Like past recent treatment, what kind of treatments have you had, and then what kind of drugs are you taking, if at all. Chief complaint, like how long did you feel these for? What are your symptoms? Like, are you feeling spontaneous pain? Are you just sensitive? Is it pain to hot, cold, and sweetness, or is it when you're biting or chewing? How long does the pain last? Where do you feel the pain? What triggers the pain? Things like this, like what provides you relief? Is there any referred pain, and are you taking any meds for this pain? Sorry. And then we have to do a clinical examination. We have to check for big things are swelling and checking for abscess, and we have to check the periodontal status of the teeth, and of course caries and restorations and things like this. So like we want to look at the facial asymmetry or asymmetry, see if there is an asymmetry. That will be a big hint that there's a swelling somewhere that might or might not be the origin, may or may not be the tooth. If there's a sinus tract, the patient might not feel much at all, but there's going to be pus coming out. And with the sinus tract, we actually have to also remember that it can also be draining through the sulcus. We have to look at the soft tissue, the tissue around where the apex is for the tooth. We need to see the periodontal status of the tooth. We want to probe all around the tooth in question and the surrounding teeth and check for mobility. We want to look at to see if there's caries or restorations, anything that can be causing an issue to the pulp. And in terms of restorations, we're especially looking for defective restorations or newly placed restorations that is causing the patient the problem they're experiencing. And then after that, we're going to do a clinical testing. I will get into these in more detail a little bit later, but we're going to do a pulp test. So we're going to test for the pulp status and the periapical status of the tooth. So for pulp, there's cold, heat, and EPT. And for periapical, there's percussion palpation, and we're going to use a tooth sleuth, basically a bite test. We'll get into more of those in a moment. And then we're going to do a radiographic analysis of the tooth. So we need new periapicals, even if they have recent ones and patients a little bit hesitant, we have to let them know why we need the new ones, which is to see the most recent status of the apical tissues, because the tissue status can change, right? So we need at least 2 of them so that we can see whether, like, if there's a lucency at the periapical, we need to be able to see have periapicals at different angles to really be able to determine whether the radiolucency is like attached to the tooth or not. Mental foramen coming to mind, right, to have a differential bite wing, and a CBCT if at all necessary. And then additional test if we need to. Selective anesthesia, we would do this. If, let's say, sometimes the patient will say have a cold sensitivity on the upper arch, but they will have a percussion sensitivity at the lower arch, and we are not quite sure which one is really causing it, then we can decide to administer some anesthetic to either the upper or the lower arch. It doesn't really matter, but just one, yeah? And if the pain goes away, that means that we have correctly guessed the arch that is causing the issue, versus if the pain remains, even though we've anesthetized the arch, that means it's the other arch that is causing the issue. So if we're feeling pain on the upper and lower arch together, and this can happen often when the patient has a new restoration that's a little high, the occlusion was not adjusted properly, then that can actually feel like we're not sure which one it's coming from. The patient will be unsure, and the testing will also be a little bit like both of the teeth will react to it. So, but if it feels like maybe it's the upper, then we will anesthetize, let's say, the upper, and if the pain goes away, that means yes, it is the upper. But if the pain remains, it's like, nuh-uh, it's the lower tooth that was causing the issue. So upper and lower is a very clean-cut way to use selective anesthesia. Infiltration is not good because, if you're not sure between two adjacent teeth, then it's really hard to anesthetize just one tooth and not the other. We can also do, let's say, posterior superior alveolar block if let's say we have a situation where upper molars and upper premolars are involved and we're not sure if it's the molar or the premolar that's causing the issue. Then if we do a PSA, it will reach the upper molars, but it will not affect the premolars. So that's another way to do it. And then there's transillumination, which we'll use a transilluminator. We'll give out a really strong beam of light. It's a really good way to see the blood flow, the vitality of the pulp, but it also really shows cracks, so it's really good for that. And then your absolute last resort is test cavity. Absolute last resort is test cavity. Okay, so that's the test cavity is when you would drill the tooth that you think is the offending tooth. Because it is going to be, if you're correct, then your guess, and most likely if it is correct, and you have a differential in your mind, it would need a root canal anyway. So you would start drilling just to make sure that you're actually the wrong tooth. Like if you have any question, you would start drilling in, but without anesthetic, and the patient should feel something when you start reaching into the dentin. So that's the test cavity, but you really want to use it as a last resort because you could be wrong and you really don't want to do that. And it's also very uncomfortable. It's very uncomfortable for the patient. Yeah, so it's just not what you want to do, but it's there for you if you need it. Pulp testing. Cold test, heat test, electric pulp test. Those are the three. Cold test is a great test. It's just you use something like endo ice, and you would spray some endo ice on a cotton pellet and place it on the middle third of the tooth to see if the patient responds or doesn't respond. It's really good for distinguishing between, most of the time normal pulps will respond to it as well, but it's also really great in distinguishing between reversible and irreversible pulpitis. Because in reversible pulpitis or normal pulp, when the stimuli is removed, so when you remove the cold cotton pellet, the patient will, after a few seconds, they will stop feeling the pain or the discomfort, versus irreversible pulpitis, you'll see a prolonged pain, even though sometimes irreversible pulpitis can actually also get relief from cold, but more often than not, they will have lingering prolonged pain, sometimes longer than 30 seconds. It is more precise than heat test when it comes to the pulp sensibility testing. So we don't actually use heat test a whole lot. It's not great, but cold test often proves to be reliable. But it is very unreliable if the tooth is calcified. So this is, and we can check for calcification when we look at the radiograph and things, right? But this is important to note, and it's also important to, on the same note, remember that regardless of the type of test it is, the negative does not always mean or like having a response or not having a response does not always mean, let's say, the pulp is dead. Sometimes they just don't feel it. And this goes for all three tests. And it is something that you always have to keep in mind. Oh, the patient doesn't feel cold. So maybe they just didn't feel it. Like maybe it is a calcification, maybe something else, but maybe they just didn't feel it. It is always a possibility. And this makes, when you do pulp testing, so you don't want to go straight to the tooth that we think is the issue, but we always want to start from a tooth that we're pretty sure is a normal tooth. And this will teach, and this goes with all three tests, right? Like any type of pulp testing that we're going to do or periapical testing we're going to do, we always want to start with the contralateral or the opposing tooth first. And I like to do contralateral because sometimes the opposing tooth can be involved, especially if there's like a high restoration or something like that. Anyway, you want to do a test there to kind of establish a baseline. So test a few teeth. And also this is teaching the patient, this is what normal feels for you. So then you move over to the tooth that we are really wanting to test and be like, okay, does this feel the same or does it feel different? Like how does this compare? But we are always going to try the tooth, get a cotton pallet, put on some endo ice there, and then place it on the tooth. And if the patient gives a response, you take it off right away. There's no reason to stay there. If the patient doesn't give a response, you stay there for about 5 seconds until you stop. And that will just mean a negative test. And so each test, but you always want to look at the whole picture instead of deciding, oh, negative, necrotized pulp. Like, really? No, it is not. We don't know. It is not enough information. We have to look at all of the things together. Okay. Then let's look at the heat test. For heat test, we would usually heat up GP sticks, gutta percha sticks. Before we put it on the tooth, we actually also want to dry the tooth out and then put some Vaseline on it so that the gutta percha doesn't stick to the actual tooth. When you heat up the gutta percha, you're going to go in and out of the flame because you don't want, you want the gutta percha to be heated evenly. You don't want it to have like hot spots and low spots. You want the temperature to be more even. Yeah, so you want to go in and out of the flame when you actually are heating it out. But heat test is not used a whole lot because it is not super reliable, and also yeah, it's just not that reliable. But also for this, if you are using it, you always want to use it first on the contralateral or the opposing tooth first. And pain that is produced or provoked by heat often says that the inflammation is acute or that the pulp is partially necrotized, like it's dying. Yeah, so that's what it often says. But again, we have to look at the whole picture. When a tooth has a small abscess periapically, heat sometimes will aggravate the symptoms, but cold might alleviate the pain. So just something to be to keep in mind. But heat testing is the one with the least diagnostic accuracy, so never use it alone. And also when you do the heat test, you would not apply the heat for more than 5 seconds. 5 seconds max, or until patient gives a response, you remove the heat source immediately. Then is electric pulp testing. EPT is great in testing the pulp sensibility in older individuals. Thermal test, so the cold test, thermal test, is not very accurate when the teeth are calcified. So in those times, EPT is a little bit more reliable. And and it's also more reproducible, the results. So EPT is really good for vitality testing. So is it still alive or partially alive or not? But it is not that great for learning whether this pulp, if it has some inflammation, so if it has pulpitis, whether that is reversible or irreversible, it's not very good for that. You want to do a rubber dam isolation if at all possible, for EPT, and you need to make sure that it is completely dry. So you would dry the area that you're working on, and you would put toothpaste on the little bit of the end of the wand or the tooth, just a little bit to act as a conductor. And you would put on a lip clip on the patient to make a complete circuit, and you would start from a very low voltage to find the about approximately the voltage that the patient will respond to. So you all, again, want to start on the contralateral or the opposing arch first, and kind of get like the baseline for this patient, and then move over to the tooth that you actually are interested in. If there is a metallic restoration on the tooth that we are interested in, this is not a very good test to use. But if it's on other teeth, if you insulate it, you can use it. You can use this test, but metallic restorations, obviously, it conducts electricity really well, so it can lead to false positives. So there's no one perfect test. Unfortunately, that's why there are several tests on hand. So that was just the pulp testing. And now the periapical testing. So we're talking the structures of the health of the structures right underneath and surrounding the tooth, the apex of the tooth. Percussion, just going to tap on the tooth, right? So, I mean, you're going to use not super strong, but like just a clear tap. Usually just doing it with a mirror handle is the most commonly done. You can just use your finger, but you want to be isolating that tooth and delivering clear percussion. So fingers, not very, I wouldn't really recommend it. But when you do percussion, try to do it in both directions, meaning vertically and horizontally. So vertical percussion and horizontal percussion. You want to do it both ways. And if the tooth responds to horizontal percussion, then it often is, and again, I cannot say that this is what it is, because with any other testing, we have to really look at everything. But if it responds to horizontal tapping, it can indicate that the source is not the pulp. Okay, so that is a possibility. So just kind of keep that in mind. So the periapical, like things like percussion, patients will respond if there has been some sort of periapical involvement, right? But often, not always is there periapical involvement. Like the issue can be localized to inside the pulp and has not reached the periapical area yet, or it might not. So that's just also something to keep in mind. Gentle force, you don't have to do that. Do it really, really strong or anything like that. And a positive percussion test in and of itself does not mean that the tooth has an endodontic disease. If there was a concussion to the tooth or a periodontal disease, it can also result in percussion sensitivity. So that is also something to note. Also, you need to palpate. You would do a palpation. So palpation should always be a part of a clinical exam that you do. But when we are dealing with a potential, like we have to make an endodontic diagnosis, you're going to just use firm pressure on your finger, and you're going to apply that on the mucosa overlying the root apex. So apex or apices, depending where we're working, facial buccal, and the lingual palatal, both areas. Positive response can be sensitivity, it can be swelling, it can be bony expansion, or it can be a break in the cortical plate. You always need to do the contralateral side as well to feel for what this patient's normal tissue feels like. But again, we have to do all kinds of tests together to really know. And it seems like I did not include the bite test, the tooth sleuth. Let me just do it verbally now. So the bite test or the tooth sleuth, what that is, it's just a plastic instrument that has a little knob where with an indent that fits over a cusp. And this is helpful because we can test each cusp separately for molars. But you basically put it over the tooth that you want to test or the cusp that you want to test and have the patient bite down, and then you'll see the patient response to that. And that will also tell you a lot about, like, if the patient is uncomfortable or has sensitivity to chewing and biting. That is also something that you definitely want to look into. Pulpal diagnosis. So we use that, and as I explained in earlier, like, we need to look at radiographs, we need to talk to the patient and gather all of this information, and now we're going to make a diagnosis. So we're going to make the diagnosis for the pulp and for the periapical structures. For the pulp, what are the things that are possibilities on our radar? The pulp can be normal, it can be inflamed, it could be dead, or it could have been treated previously. So normal is just normal. Inflamed means, like, dentistry, speaking dentally, we're talking pulpitis, right? And inside pulpitis, first what we need to know is, do we think this is a reversible pulpitis or a irreversible pulpitis? Can this pulp become normal again, or can it not become normal anymore? Is this just downhill from here? And from irreversible pulpitis, the patient may or may not have symptoms related to the pulpitis. So there's symptomatic irreversible pulpitis and there's asymptomatic irreversible pulpitis. But either way, the treatment is the same because the pulp is inflamed and it's irreversible. So you arrive at a root canal treatment. When the pulp is dead, we call that necrosis. And then previously treated, or has been treated, there will be previously treated, which is a tooth that has received a root canal treatment from the start to finish, like it's done, or a previously initiated therapy, like half completed, not all the way done. So that's also something that you'll see here and there. Okay. A normal pulp. We're talking, when you say normal pulp, we're talking of a pulp that is clinically symptom-free and generally normally responsive to pulp testing. And I say generally because, as I said earlier, if the pulp has a lot of calcification or the nerve endings are dead, like whatever, for whatever reason, the patient just might not feel the stimuli, right? Cold, EPT, heat, they just might not feel it. But generally, we're talking about a symptom-free and normally responsive to pulp testing. We're not talking histologically normal, just clinically normal. Mm. And like the testing results to, let's say, cold test that we are looking for, or like is the classical depiction of a normal pulp, would be a very mild response to cold testing, and that result should also be like it should leave fairly quickly, so transient. Like they should feel it fairly soon, and then once you feel it and like you remove the cold, and then the patient should be like, oh, I'm fine now. Like it was like, oh, I felt a little bit of something and like it's gone. Oh, I'm fine. This is the classic normal pulp. But you cannot arrive at this kind of conclusion without comparing the tooth in question to adjacent and contralateral teeth as well. So you always want to start from other teeth. Can't stress that enough. Reversible pulpitis means the pulp is inflamed pulpitis, but it seems like it is reversible based on the findings, based on the subjective findings, so what the patient says, and the objective findings from the things that we are doing to the patient. It seems like the inflammation isn't that bad, and if we take good care of this tooth will likely return to normal, or the pulp will become normal again. Usually what we see in cases like this is when there is a stimulus like cold or maybe sweet, they feel uncomfortable, and it will go away within a couple of seconds or so after you remove the stimulus. But the discomfort with the stimulus is it's more than what you saw at a normal pulp. It's like in the normal pulp, it's very mild. It's not that uncomfortable. But if it's reversible pulpitis, they would be like, ouch, like, they might jump a little bit like that, and that's kind of like a good indicator. But again, you should have done testing on other teeth first, so you know what this patient's baseline is, so you compare it to that when you work on the what you think is the offending tooth. Usually what we see with like this is caries, deep restorations, things like this. Dentinal sensitivity, like exposed dentin, in and of itself is not an inflammatory process, but the symptoms of exposed dentin mimic that of reversible pulpitis, so also something to keep in mind. Usually with reversible pulpitis, there are no significant radiographic changes in the periapical region. So the apical area of the tooth, the surrounding structures of the tooth, has not been involved. It's just the issues contained inside the tooth. Usually if you see periapical changes, then a root canal treatment is gonna be indicated. And the pain that this patient is experiencing, it is always going to be linked to a stimulus. It's not going to be spontaneous. It's not going to be spontaneous, and it's also not going to be lingering. So when you remove, let's say the patient feels discomfort from chewing or for something like that, but when they stop chewing, it should go away in a few seconds. But if it stays, that points us more towards irreversible pulpitis. This is an assumption, right? That this pulp can return to normal after we manage it. So we always need to evaluate this tooth further to determine whether or not this reversible pulpitis that we are saying that this tooth has returned back to normal or not. Yeah, so that's reversible pulpitis. And then there is symptomatic irreversible pulpitis. Symptomatic irreversible pulpitis means that pulp is inflamed, patient feels symptoms, like this is generally, I mean, like I'm saying this lightly, but this is generally a lot of symptoms, right? And the pulp is inflamed. The inflammation seems to be at a degree that there's no coming back. So yeah, no more healing or anything like that. Like root canal treatment needed. What we will see in a pulp or a tooth with this would be when there's a pain, when there is a cold or heat or something applied, there is sharp, strong pain that also lingers. And by lingering, like this is like a big distinguishing factor between reversible and irreversible pulpitis is whether the pain lingers or not. If it lingers, then that's not good. Also, when it becomes irreversible, like the pain can just be there, like without a stimulus. Spontaneous pain or unprovoked pain is that usually what we call this, right? Also, sometimes the patient might say things like when I lie down or get up or whatever, like when I change my position, the the pain changes, and this is also a bad sign. So the postural changes of the patient might accentuate the pain, and often they will also say like ibuprofen is not working anymore. This is something to look out for. Etiology is similar to reversible. So basically, things that offend the pulp is what is causing all of this. So deep caries, extensive restorations. Sometimes if the tooth is fractured and it exposes the pulp, this will happen as well. Very often, not always, but very often, the inflammation has not reached the periapical tissues. Okay, so irreversible pulpitis, we don't always see periapical changes, which means that the periapical testing might come back normal. So, but that just means that the periapical structure is normal. That says nothing about the actual pulp, right? So just a clear-cut distinguishing in that. And so the history and like the thermal testing, like that's what you use to test the actual pulp, and that will be what you use as the basis of your diagnosis that it is symptomatic irreversible pulpitis. Asymptomatic irreversible pulpitis. That means that the pulp is inflamed. It is past the point where it can heal itself. Root canal treatment is needed. However, the case does not have clinical symptoms of, let's say, a severe pulpitis or whatever, and it may respond normally to thermal testing. It may have had trauma or deep caries or something like that, but it also often might result in just normal thermal testing as well. But still, it's asymptomatic, it's irreversible, and it's a pulpitis. But it's not necrosis, so that comes next. Pulp necrosis. That just means that the pulp is dead, which means, again, we need to do a root canal treatment, which is the same as what we would have done for a irreversible pulpitis as well. So the pulp is just completely non-responsive to all of the things, to all of the pulp testings, sorry, not all of the things, because it might respond to periapical testing, but the pulp testing, it is non-responsive, and it's also asymptomatic because it's just dead, it can't feel anything. Pulp necrosis in and of itself, it does not cause apical periodontitis, meaning just because the pulp is dead, that in and of itself does not mean that we will see, let's say, an issue with the apical tissues. So pain to percussion or even like radiographic evidence of the bone being broken down, this may or may not happen. Let's say that if the canal is not infected, it might not happen. If the canal is infected, if you give it enough time, it will generally start spreading over there. But like trauma and stuff can just kill the pulp, but there was no infection that caused it, and so the periapical tissue might be completely normal. But again, pulp testing in and of itself, like you cannot just do that and say, oh, the pulp is dead, because sometimes the tooth simply does not respond. So all testing is comparative. So if the patient's other teeth also don't respond to things, then you have to back off and be like, okay, we cannot use pulp testing as a basis to trying to diagnose the status of this pulp, because none of your teeth are responding. But if other teeth respond and this one responds differently, then we use it, right? Okay. Previously treated tooth, easy. You see on the radiograph that the canals are obturated, and obturated with like permanent, like gutta-percha or silver cones or something like that. And because when we're not just talking like temporary restoration materials, right? Because that will be previously initiated therapy, not finished. The tooth that's been previously treated shouldn't respond to thermal or electric pulp testing, but if there was a missed canal or something like that, it might. Previously initiated therapy means that it just means what it says. It's been started, but like you didn't finish. So like the patient might move, or just like the dentist might have said like, hey, we're going to put temporary material and watch your periapical tissues, see how it heals, and then we're going to obturate it. But then the patient never came back because they no longer started to feel pain. That will be some reasons for previously initiated therapy. Not exactly what we want to see, but yeah, so that's that. So the previous slide, pulpal diagnosis, I just kind of organized it in terms of how my brain works, but the official terminologies that you want to remember are these: normal, reversible pulpitis, symptomatic irreversible pulpitis, asymptomatic irreversible pulpitis, pulp necrosis, previously treated, previously initiated therapy. I just like to put it as like normal, inflamed, dead, treated. But these are the ones that like this is the exact terminology that you want to use when you are either like when you're talking to somebody, in an interview setting, or you're writing it down to write down like what you think is the issue is when you're doing case studies or whatever. This is a terminology you want to use. So be exacting and remember these. Apical diagnosis. So what is going on around the apex, or starting the apex going around? It can be normal. There can be apical periodontitis. There can be an abscess, and there can be condensing osteitis. So an apical periodontitis may be symptomatic or asymptomatic. If there's an abscess, it might be chronic or acute. So let's look at each of these further. Normal apical tissues. Percussion, palpation, radiographically, just nothing really stands out, right? Like percussion, normal, same as other teeth. Palpation, normal, same as contralateral. You don't feel swelling or anything like that. Lamina dura, intact. Periodontal ligament space, uniform. Yeah, that'll be normal normal apical tissue. And in terms of like what the things look like, because now as we're talking about the apical tissue, we can some things start showing up on radiographs. For radiograph examples, that will be in the radiology section of the course. So, symptomatic apical periodontitis means there is inflammation around the apex of the tooth and there are symptoms. So, inflammation of the apical periodontium producing symptoms, which generally involves pain to biting, percussion, palpation, all three, just one of the three, whatever. Yeah. So we're talking percussion, palpation, biting, pain. There may or may not be radiographic changes. Okay. Because there needs to be a lot of bone breakdown to really see things in a radiograph. So depending on the stage, you might even see a normal width of the PDL. Or, I mean, there might be a slight swelling or a slight periapical radiolucency. They are all possibilities. So, but just because there is a apical periodontitis does not mean that you will always see something in the radiograph. But especially the symptomatic apical periodontitis is where you may not see, well, that and the acute apical abscess, but you may not see radiographic changes. So if there is a lot of pain to percussion or palpation, it is very highly indicative of a dying or degenerating pulp, and we'll need to do a root canal treatment if the tooth has symptomatic apical periodontitis. It does need a root canal. Asymptomatic apical periodontitis. This is inflammation of and destruction of the apical periodontium, and the reason for that, or the origin, was the pulp. And you will see a apical radiolucency, but it will not have any symptoms related to it. So we don't see pain to percussion, we don't see pain to palpation, but we know that there is apical periodontitis still, even though our clinical exam showed nothing. We know that apical periodontitis is there because we see an apical radiolucency. And remember, 2 angles for the PAs, so that you need to make sure that that radiolucency is actually because of, or it's related to the apex, or I mean, sometimes if there's a side canal, that too, but yeah, 2 angle radiographs at least. So this is not something that we can just judge with one PA. I guess that's what I really wanted to say. Chronic apical abscess means that there's an abscess, but it has a sinus tract, so the pus is being discharged. Yeah. So there's an abscess that's being discharged, so there's no pressure build up per se. Yeah. So there's this inflammation in the apical tissue, and the pulp is dead by this point, so necrosis. But the patient doesn't really feel much at all. So gradual onset, little or no discomfort at all, and intermittent discharge of pus through a sinus tract. And remember, the sinus tract, like some just drain through the sulcus as well. So you have to really look for this. Generally, by this point, there's going to be signs of bone destruction that you see through radiographs. So you should see some radiolucency. And when you see a sinus, you always have to find where the origin is. So gutta percha cone, like just gently place it in the opening, and again, radiographs at least 2 angles to find that out. That is chronic apical abscess. Oh, sorry, did I just skip? Yeah. And then there is acute apical abscess. Acute apical abscess means that there is there's an inflammatory reaction to a pulp infection and necrosis, but it's really fast. And it hasn't yet established a drainage, which is why there is like swelling of the tissues associated with it. And because this one is a fast onset one, there might be no signs of radiographic destruction. And the patient will often have, let's say, fever and lymph node swelling and things like this, like malaise often comes with this acute apical abscess. Condensing osteitis. This is so up until this point for the apical structures, if there was a change in a radiograph, it was radiolucency that would have come up. Condensing osteitis is a radiopaque lesion. And it's basically the bone is responding to a low-grade inflammatory stimulus by building up more bone. And that's why you will see a diffuse radiopaque lesion around the apex of the tooth. And you can see there are more photos of radiographs and things like this inside the radiology section of the course. And so the things, like the exact names that you want to have ready in your back pocket is normal, symptomatic apical periodontitis. Oh, I'm so sorry. I mean to say asymptomatic apical periodontitis, chronic apical abscess, acute apical abscess, and condensing osteitis. So have these in your back pocket and remember those for that. As I said, what I've just done was a live recording for a module in the clinical interview course, which is a course that we've put together for the clinical interviews. Lots of schools do treatment planning or just, they test your clinical knowledge in their own creative ways. And this is a course that we have put together to prepare you for that side of the interview, because with all of when a school tests you for something, anything, they do that because they are considering that to be important information in discerning whether a candidate should or should not be taken in to the program. So you really need to, oh my gosh, especially these days with the competition being like it is, you don't want to botch any part of the interviewing process, right? And this includes the bench test, if they're doing that, the interview, if they're doing that, and anything clinical, if they're doing that. All of them is so, so important. The clinical interview course will be ready starting next week. And let me just say a few more things about that course, and then I'll get to your questions, or I'll jump over to the chat and see if there are questions. I don't know. But I do want to let you know that the clinical interview course, a lot of the content is not freshly recorded. They are from previously recorded workshops, because I have years of content that I have created. And a lot of it was relevant to this. So, and this is how we're actually launching the course so quickly, because you guys needed it so fast. We got so many requests for this. So I was just like, well, what can we do? So we're pulling together things from previously recorded material. And this also includes some material that was from the bench test mastery course. The entire we have a course called Dental Radiology and Radiographic Interpretation. We just actually integrated that course into the clinical interview course. So as soon as the clinical interview course is launched, the radiology course in and of itself is not going to be available just to do it on its own. It's just going to be a part of that, and then lots of workshops that I've done, and then the next several weeks I'll be adding a few more modules to it by doing these workshops with you guys live. So that is how the clinical workshop is coming together. Okay, so now I am going to look at some questions. Can I register now for the clinical interview course? Is it based on the OSCE format? You cannot register yet, but you will be able to next Wednesday. There will be a module for the OSCE, and this is going to be recorded live next week because there are some, like Michigan and somebody said another school, but anyway, schools are doing this. So yeah, there will be a format, there will be a module on that that will be recorded next week. If the tooth is previously treated but were exposed, when I will say it needs to be retreated, exposed. If the tooth is previously, basically you're asking like, when do we have to retreat a tooth that has been treated before? So if for a retreat, those are challenging, but you would see, let's say, the radiolucency that is increasing in size, or the patient's symptoms are either not going away or they went away and they're returning. So they're mostly either symptom-based or radiographically based. And then that will how you will decide on a retreat. Will we get the recording of this? Unfortunately not, because this is going to be a part of the clinical interview course. Infiltrating in the maxilla, the PSA block is what I'm guessing what the guest JP was asking about. So I was talking about selective anesthesia for figuring out basically which tooth is the offending tooth. So if like the PSA block will block the molars of the upper arch, but not the premolars. So if you are trying to figure out which tooth between, let's say, a molar and a premolar of the upper arch, you can administer a PSA, and if the symptoms go away, that means the molar is the right one, and if they stay after you give a PSA, that means it's probably the premolar. Is Michigan done with their interview invites? I wish I knew. I am not the school. I'm watching things, Sammy, just like you. But hopefully you'll get an interview call soon from them. I wish you the best. Okay, now let me pop over to YouTube comments. When do we use pulp testing? Do we use it for reversible pulpitis or just to differentiate between asymptomatic pulpitis or periapical diagnosis? So pulp testing is something that is done like if the patient has tooth pain, like it's always just brought out, because you want to know if the patient is talking about some kind of pain. It's upon us to figure out, okay, what is the extent of this pain, try to recreate this pain. And often they'll say like, oh yeah, like when I eat something cold or something like that, it hurts. Then we want to try to reproduce that pain if possible, right? And same with, like, let's say if they say like, I feel pain when I chew, then we would bring out the tooth sleuth to try to reproduce that pain upon biting, so that we can view the patient's response and compare the patient's response to the other side or the opposing side, which is supposed to be normal. So we use it for any anything where we assume that there might be an issue. And I mean, it's an easy test to do. We just like put cotton rolls and we dry the tooth and endo ice on a pallet and then just put it right there. We have our reaction within a few seconds. So anytime we suspect that there might be an issue with the pulp or something like that, we would bring it out. Let's say there's like even deep caries, right? And we want to know like, oh, does this like, do we like, when we see a radiographically deep caries, will we go about just treating this as caries, or because radiographically there's an overlap with the pulp or whatever, like it seems like it's approaching the pulp, but there may or may not be, like we don't know, or it's approaching the pulp, but we're not sure because we don't know, right? We can do the pulp test to see like, okay, how is the pulp responding? Has the pulp been has the pulp been affected by the caries that we're seeing? So it is much more than to just differentiate between, to figure out between the two, but it's used very early on in the examination process. Annie is asking, do we need to take the clinical interview besides the bench test? When is the clinical interview taking place? So this depends on the school. So we are preparing it as a separate course. Yes, we are, because some schools have it, some schools don't have it. It really just depends. So that way you can do it if you want to do it. Let's say you might be going to school, and especially right now because of COVID, some schools are only doing online, let's say a virtual bench test that does not actually involve hand skills assessment, but is more of this kind of thing. Then you don't have to do the entire bench test course, you can just do the clinical interview course. So yes, we are preparing it as a separate course that will be ready for anybody interested to join starting next week. Can a tooth with condensing osteitis be diagnosed other than radiographically? Nah, it's a radiographic thing. Is root canal treatment mandatory for condensing osteitis? No, it is not. Criteria for considering that the root canal has failed and has to be retreated. I'm going to guess that you're asking what is the criteria to consider that a root canal has failed and has to be retreated. Patient symptoms and radiographic. We look at those separately and together. I believe I just touched on that. I think that was like one of the first two questions I answered in response to somebody else. So I think that should have answered your question. Okay, if the tooth is previously treated with apical radiolucency, but aesthetic is the main chief complaint, what treatment would you recommend? Wait, what? The tooth is previously treated, you mean a root canal treated with apical radiolucency, but aesthetic. So if the tooth already has a, so this will often happen on, let's say, anteriors, because after you do a root canal treatment on an anterior, a crown is not mandatory, right? You'll make the decision based on how much tooth structure is remaining, things like that. But like for molars, you have to, like, it's part of the treatment. Like it will fail if, let's say, you just finish off a root canal and just put in composite. Like you don't do that. That's not standard of care. But for anteriors, if the remaining tooth structure and everything is sound and it is okay, we can just place composite and call it done. But if aesthetic, like sometimes that tooth might get discolored. But if there's an apical radiolucency, this is something to watch, right? Because like we don't know. What we want to see is, has the apical radiolucency stayed the same? Is it getting better or is it getting worse? So with just one snapshot, without seeing the time progression, we cannot make the decision. Yeah, it would, for standard of care to be established well, we need that. Now, if the patient is just really like, I need something, then a possibility will be to do veneers, because we can still, if needed, access the axis that we just finished off with composite without actually touching the veneer. That's just placed in the labial. So that is something that you can do, but you have to look at, again, the tooth and all of this kind of stuff. But if the discoloration is severe, then it might be a little bit too much to do it with a veneer, because there's already been loss of tooth structure due to the root canal treatment, and then like shaving off more tooth structure from the labial side. If discoloration is a lot, like you have to shave off more to be able to mask that color, and that might leave the tooth too weakened. And in those cases, you will need a full coverage crown. Now, if there's a radiolucency, if that is if it's getting better, sometimes you might deem it is okay to just go ahead and place a crown on top. So it really is a case-by-case basis. But I think more important than exactly what it is that you should do is to know that what are the things that you need to consider, so that you can put them into consideration when you are doing your treatment planning, or like telling the professor that you're interviewing with, in terms of like what's going on in your brain when you're trying to figure out. Because what they actually really don't want to see, like, oh, this is the answer, because what's more important for a clinician is to have a sound reasoning process. So it is more important for you to share your reasoning process than to be like, this is the answer, done. Like that's not how you want to approach it. So hopefully, even though my answer was not straightforward, this is what you do, like hopefully that makes sense. What is the treatment for pulp calcification? Nothing. Because why touch? Like you'd only, let's say, remove the pulp or do a root canal treatment if the patient really needs it. And a calcified pulp is something that just happens often with age. You don't want to touch it unless it is also experiencing other issues that we previously discussed. And can I ask a question concerning the education for international dentists? So does 2 years of advanced standing programs give you a license to work in the US right after graduation? Yes, it does. Yeah, so basically, if you finish your advanced standing program, which is most of the time 2 years, sometimes a little more, you are basically graduating as a graduate of that school. Let's say like, if I'm, let's say, wanting to get a license in a state that I currently do not have a license in, and if I have not practiced in whatever state I'm practicing in right now, if I practiced here for, let's say, like less than 5 years, and so my license is not going to transfer by reciprocity, then I'll just need to show, let's say, my degree and my test passings and things like that, right? But when I do that, like, it just says that I'm a UCLA graduate. It doesn't say like, oh, you are a UCLA advanced standing program graduate. Like, no, you're just a graduate of that school, and you're treated equally from there on out. Sorry. In acute apical abscess, the pulp can be vital or non-vital? Acute apical abscess, the pulp is oftentimes non-vital, but it also can be partially necrotized. So there can be some response. This, like, when you learn this as like you're doing it right now, it sounds so straightforward, but pulp testing is really hard, or it can be really hard, and can be really, really challenging because of things like partial necrosis. Like, let's say molars, like one root is affected and the other root is not, or one canal is affected and the other canal is not. And it's just like we have to like piece together these pieces of the puzzle. It's not as straightforward. Once you start like doing this on real patients, it's not as straightforward as it just sounds like. Or, I mean, when you do this on real patients, I take that back. When you do this on real patients, if there's grounds for a root canal, the diagnosis is not quite as important anymore, right? It's not super important to figure out whether, I mean, this is a bad example because symptomatic versus asymptomatic is fairly easy to distinguish, but it's not that important to figure out whether this is symptomatic irreversible or asymptomatic irreversible pulpitis, because in either case, the treatment is going to be a root canal. Or it's also not important to figure out whether this pulp is completely necrotized or partially necrotized, because either way, necrotized, you need a root canal treatment. But in terms of like laying out these diagnoses and to really get to the bottom of things, it can be really, really challenging. Okay, so let me hop back and see. There are 2 more questions on our site. Let me get to these now. If the tooth is previously treated with apical radiolucency, oh, I already answered this question. Can you share what the clinical interview course contents include? Case management, treatment planning, radiographic diagnosis. Does it include test/assessments? I'm not exactly sure what you mean by test and assessments, but yes, it includes cases. It includes treatment planning and cases. I already said cases. It includes radiographic diagnosis. It also includes when you see because what's also often done is showing you, whether it is like in person, like handing you a cast or a photo, or like virtually showing you a photograph of a prep, showing you a prep and basically saying, hey, what do you see in this prep? What's good, what's bad, what would change, why? So it includes that kind of thing. What else does it include? It includes RPD design. I should have come more prepared for this, but yeah, that. And then next time we're going to do OSCE, so that's going to be a part of it. And the week after that, we're going to be doing a one about the periodontal diagnosis, which we're already at an hour and 15-minute mark. I figured I just need to break this, what I was going to do all today, into 2. Otherwise, I would just be going through the content too fast, which is why we did that. Cost right now, it's looking at $397. I heard some schools are moving to the Cura Talent platform for interview admissions process. Do you offer it in the interview course? Can you please share some resources that we need to look into? I need to look into this myself, so I cannot help you with this at the moment. However, I wouldn't worry about the platform you're going to be interviewed on. I would just worry about the content you'll be delivering. Yeah. Okay. So that is all I have prepared for you. One more question that came up on YouTube. Will there be a combo of clinical interview course and dental radiographic interpretation? Great question. The dental radiographic interpretation course is going to be absorbed into the clinical interview course. So once the course is launched, I just brought the content over, because I can't do one without the other. You know, like you need the dental radiographic interpretation course to do a clinical interview course that is well-rounded and has what you need. So it's going to be absorbed inside that other course. And the dental radiographic interpretation course will no longer be available to as a standalone starting next week because of that. Okay, so I hope you found this helpful. No matter how hard I try to stay right on time, I'm 20 minutes over. So thank you so much for sticking around for this long. As I said, next week we're going to have another workshop about OSCE, and the week after that is going to be periodontal diagnosis. So stay tuned for those. And starting next week, the clinical interview course will be ready for you to join as well. And that's it. So thank you so much for coming. Have a great rest of your day, and I will see you next week. Bye now.